parasternal long axis view. Third of the forced intercostal rays, point the pointer notch toward the right side of the patient. Okay, just next to the sternum. Okay, once you get an image, you can tilt it or slide it, get a high plaques, low plaques, whatever measurements you want to see. Some of the things you don't need to remember right now, the aortic root dimensions or what you're seeing. Just get accustomed to handling the probe and get an image of what the chamber that you see. For starters, that is good. So this is how we are cutting. This is the right shoulder. This is the probe pointer. Cutting it right here. If you open it up, this is what you see. Superior to the apical part. Okay. So this is when you see from anterior to posterior you go, this is the right ventricle. This will be to remember the probe is here. Okay, over the chest wall cavity. So you're going from the superficial to the deeper part of the heart. The superficial is the RV, which is the most anterior one. Then this is the intraventricular septum. This is the LV. So right ventricular, left ventricular, the septum between the two, LV, and this is the mitral valve. This is the left atrium. So what's the blood going like? Coming from the LA, going into the LV, going out of the aortic valve. This is all you can see right. Okay. Have this image in mind. Just absorb this for a second. RV, LV, LA, aorta. RV, LV, LA, aorta. Okay. This is the valve. This is mitral valve. You can see the caudate tendon also. Blood is going here. This is the systole of the left ventricular, left atrium, going to the left ventricle, coming out of the aorta. These are the aortic valves. And above it is the RV. You cannot see the connection from the RV to the RA, but in this view, the RA cannot be seen. Okay, this is the same view. And this is the M mode. So this was the 2D mode. This is the line cutting. Okay, wherever this line goes, this is the M mode. Okay, this M mode will show the relative movement with the heartbeat. Okay, this goes in M mode. So from superficial to deep, this is the right ventricle. So this will be the right ventricle. The next is the, in this view, is the left ventricle. This is the left ventricle. Earlier on, it was the, this was the, through cutting to the aortic root, and then below this, below the aortic root, this came the LA. Okay, I'll pause it for you. So earlier on, he was cutting from here. This was the right ventricle, aortic root, left atrium, because this was the structure that were cutting here. When you move this, if you can, hopefully you can see this dotted line. Now the line is shifted here, so the image has shifted. This structure matches this structure. That is the right ventricle. Next structure matches this structure just at the base, with the valve and the left ventricle. Why it is important here is because at this point, we'll see in the next slide, is the velocity time index is calculated, which is important in your measurements for assessment of shock index. Okay. So short axis view 2D mode, and long axis view 2D mode, and parasternal long axis view M mode. Okay. So you don't need to, understand everything right now. Just get yourself oriented, because this is just a starter for you. This is what you have to see when you practice and study further. This is now the color Doppler mode. You can see. So towards the probe is red, and blue is away from the probe. The probe is here. This was centered on the mitral valve. Okay. Right now it's difficult to understand, but with practice you can even see regurgitation. Though much regurgitation is there. This is the aortic valve. Okay. Okay. So we had the 2D mode, the M mode, and the color Doppler. Then is the parasternal short axis. Okay. As if you remember, I will go back to the image again. Short axis. right shoulder, 90-degree turn from the parasternal long axis, 2 o'clock short axis. And we are cutting the heart like this. Just 1 second. Okay, sorry. Okay. So this is a short axis. So we go to the right shoulder, get a more apical view. And so if we move towards the right shoulder, we go towards the apex. If we move a bit away from the right shoulder, we get the base of the heart view. This is the short axis. Okay. So these are structures that we see when we cut across this. In this, if you're rotating towards the left shoulder, this is what you're getting. This is the right ventricular outlet going towards the pulmonary valve. Okay. This is the aortic valve. This is the right atrium. And this is the left atrium. You can tilt if you go towards this. This is towards the apex, this is towards the base of the heart. So depending on what you want to see or the view you want to change, you can tilt your probe and get the information. Okay. You can see the aortic root. Okay. Now, first remember this image. Right ventricular, RA, LA, aorta. Okay. Interatrial septum. Right ventricular, RA, LA. Right ventricular, RA, LA, and this is the aortic valve. Okay. This is going rightly to just your basing at the root of the aorta. So depending upon base level, we are going more towards the apex, we're going away from the apex. You can see little info. Again, you don't need to dwell on the images. You can practice and you'll see, just to give a fair idea. What else you can see coming from the whole of the base to the apex of the heart, you can give different views at the short axis. Okay, so we learned the parasternal long axis view. We got an idea of the about the parasternal short axis view. Now we have the apical 4-chamber. This is maximum, mostly you feel where the maximum pulse is around. Yeah, you feel for the maximum pulse, wherever the maximum pulse is, this is where you will place the transducer and the tail will be away from the patient's right shoulder. So this is at the apex. Okay. Cutting right through the heart, give you an idea of all the 4 chambers. This is the patient position. This is where it is lying away from the left shoulder. The pointer will be towards this direction. Okay, and this is cutting through the heart. So this part is this part. The apex is the more superficial part, and the base is the most distant part. These are the view. These are the things that you see. This is a probe. The rays spreading out like this, cutting from the apex. And then this is the RV, this is the LV. Even if it's not written, you can see, always know that LV is the bigger chamber, right ventricular is always the smaller chamber. Okay. This is the LA, this is the RA. Okay. LA as a left ventricular, left atrium, right ventricular, right atrium, right. LV, RV, LA, RA. Sometimes you can get a 5-chamber view also. We will get an aortic outlet here. You see, just a while back he did it. Yeah, this is the aorta. The LV draining into the aortic outlet. So we call that a 5-chamber view also. 5th chamber being the aortic. And this is the, we have put a pulse wave Doppler right across the mitral valve. You can get the idea of the contour, idea of the velocity, again, beyond the purview of what you're discussing, but just to get an idea. You get a pulse wave Doppler also. This is the systolic and the diastolic. Two-chamber view, same 4-chamber view, 30 degrees counterclockwise. We will get a, okay. So this was flattened out. Now this is the 2-chamber view. We are just cutting it across. You're turning it by 30 degrees. Get an idea of just the left ventricle and the left ventricle. Get an idea of the anterior and the inferior walls. Last view, mostly that we follow is the subcostal view. This is a good view, especially for ICU setting. This is the commonest one that we use, especially patients who are ventilated, who have COPD, have hyperinflated lungs, might have had thoracic trauma, dressings. You get a lot of images right from the pericardial effusions. You can see the tamponades, you can see the IVC, you can see most of the chambers. So a lot of information is obtained from the subcostal view. The patient will be lying supine, as most of the ventilator patients are, and at a 45-degree angle, 2 finger widths below the xiphoid process, we place the transducer and point it towards the patient's left shoulder. So this is the subcostal. This is the diaphragm. This is subcostal area. Pointed towards the left shoulder, we place the probe at a 45-degree angle, and we get this is just okay. Right, you will get a lever that gives you an acoustic window, and this is what we get. Okay, the nearest to the probe will be the some part of the RV, RA, LV to the left, and the LA will be the farthest away from. Well, you are now from the inferior part, you are the subxiphoid part. Okay. So RV, RA, LV, LA. So you get an idea about the pericardium. This is the pericardium. You get an idea of there is fluid accumulation here. You can get an idea of the pericardial fluid is there. You can go for pericardiocentesis. You can see the relative size of the chambers. Okay. And if you want, if I'm not that good at that, if you can see the valve incompetencies also. Now, if you want to see the IVC, okay, you can get an IVC. How to get an IVC? We turn the transducer perpendicular to the patient. So right, it was cutting like this. We turn it like this to the patient. Get a coronal view, and we tilt it left to right to bring the IVC into the view. So IVC will be a bit towards the right side. Okay, the aorta is towards the left side, and you can see the IVC entering the right atrium with this view. So tilting the patient's right, if you tilt the transducer towards the right, it will cut across left to the aorta. Turn it to the left, it cut across left to the right to the IVC. So this is how we're getting it, and this is what we see in the perpendicular action. This is the IVC. And how we differentiate from the aorta, the IVC will be entering the RA. This is the hepatic vein which is entering the IVC. This is the liver. Okay. This is the RA, and this area is mostly the diaphragm, just below the entry point of the RBC to the area. And the later slides we'll see where we use the IVC set. So there are a lot of calculations that we might or might not do. Velocity time index is one important thing. Stroke volume, cardiac output, IVC assessment. We do to see for the causes of shock. I'll be seeing the later part of the lecture. Okay. LV systolic and diastolic functions. We'll see right ventricular function. We see LV systolic function will be in left ventricular failures and cardiac shock. It's important. RV systolic function is important for pulmonary embolism. You see the pulmonary hemodynamics again for the pulmonary embolism. Pericardium assessment you will see for any pericardial effusion or tamponade. And then this is more of a cardiac thing, is serrative valvular. So if we come from here, this gives you an idea of the fluid status. Velocity time index, stroke volume, cardiac output, and IVC assessment. Okay. This gives you an idea. So this was about the hypovolemic shock. This is more about the cardiogenic part, the LV functions. This is more of about the pulmonary embolism part, the RV function, pulmonary hypertension. This is about the pericardial effusions or tamponade.